All right, welcome everybody. Thank you for being here on a Monday morning at 8 a.m. We're all excited and caffeinated, I'm sure. But I am pleased to welcome everybody here to the Laura Mann Integrative Healthcare Lecture Series. The Osher Center for Integrative Health at UVM's Laura Mann Integrative for Healthcare Lecture Series has brought experts in the field together to educate and support our community for nearly 15 years. Free to the public and often presented during grand rounds, these events honor the legacy of skilled, beloved, and visionary midwife Laura Mann, who built the first center in the region devoted to integrative healthcare, which merged with UVM Integrative Health in 2015. These lectures are designed to engage multiple populations and increase our understanding of how a full whole health approach can optimize the health of individuals, communities, and our planet. Today, I am thrilled to introduce Dr. Allison Applebaum, clinical psychologist, writer, researcher, advocate, and someone who truly embodies their mission. Dr. Applebaum is professor and director of the Stephen S. Elbaum Family Center for Caregiving in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai, which is a mouthful. Her work focuses on addressing the needs of caregivers, the family and friends of patients who serve critical and often unrecognized roles in the healthcare system. I lost my spot. She works with healthcare systems worldwide to develop support programs for caregivers, draws attention to their unique needs across various illness and care settings, and implement systems-level changes that facilitate support and integrate caregivers more formally into the healthcare team. She's also written eloquently about her own experience as a caregiver with advice to others in her book, Stand By Me, A Guide to Navigating Modern, Meaningful Caregiving. Dr. Applebaum is a true pioneer in the field of caregiving, and I've admired her research for a very long time. And as I've gotten to know her as a person, I've become even more of a fan. So I'm thrilled to welcome here today Allison Applebaum.
All right, can you hear me? Mic's on? Fantastic. All right. Thank you so much for that incredibly beautiful, generous introduction. Good morning to everyone. Hopefully you're all awake and caffeinated. I apologize in advance. Apparently, if my hair touches the mic, you're going to hear some awful sound. So my apologies about that. Is there? Perfect. All right. So I should probably just start by my disclosures before I say any other words. And these are unrelated to anything I'm speaking about today. I want to take a zoom out lens on family caregivers in the United States, talk about who they are, the supports that are available for caregivers, a bit about my own work in developing support programs, and end with some steps that I'm hoping can be taken here at this institution to support family caregivers. I always like to ground my talks in the words of former First Lady Rosalynn Carter. She was an incredible advocate for family caregivers, and she devoted her public service to addressing the mental health needs of family caregivers. And she said that there are only four kinds of people in this world: those who've been caregivers, those who are caregivers, those who will be caregivers, and those who need caregivers. So this is a role that touches everyone who's in this room in person, everyone who's in the Zoom room. It's a role that we enter and we exit repeatedly throughout our lives. It's one that deeply changes who we are and the trajectory for our life moving forward. Now, I want to be very clear today as I speak about caregivers and caregiving that I am not speaking about parents taking care of children who are perfectly healthy, as exemplified by this picture taken the day that I was born and the day that my dad became my dad. Instead, I'm talking about the care we provide to our parents and partners and children and siblings and friends who live with chronic and life-limiting illnesses and disabilities and mental health challenges and depend on us for support, as exemplified by this picture taken on my birthday 32 years later. Certainly what these two pictures have in common, though, and what these two caregiving or caring roles have in common is love. And that, of course, is the heart of what it means to be a caregiver. So every 5 years, the National Alliance for Caregiving conducts studies where they canvass the state of US caregivers, and their latest data came out in July of 2025. And what the data highlighted is a significant increase in the number of caregivers in the United States that are currently at least 63 million caregivers. This is a 10 million increase up from 2020, and we anticipate this is a slight underestimate, and it's likely only going to continue. Caregivers are, perhaps not surprisingly, predominantly women, and on average, they are 50.6 years old. But I want to draw your attention to the growing number of adolescent and young adult caregivers between the ages of 18 and 34. So these are individuals for whom the caregiving role places very significant impediments to development in the area of education and employment and social relationships and family building. This is a group who's really in need of our support. And I also want to acknowledge the growing number of child caregivers. What's really striking about the NAC data from July is that 13% of care recipients said, you know what, a child has been involved in my care. And I think that there's really an invisible epidemic of child caregivers, which we're going to be bringing out of the shadows in the near future. In terms of who caregivers are, they predominantly identify as a relative, though certainly you can be a friend or a neighbor or a colleague. And in terms of care recipients' illness or the reason they're receiving care, the most common reason is old age or aging, and second being Alzheimer's disease and related dementias, which I think is unsurprising probably to anyone in this room. In terms of the duration of care, on average, caregivers are in the role for 2.5 years, but what you'll see is a good number are in the role for much longer. You'll see that 29 are in the role for 5 years. 15%, this is a decade-long or longer experience of caregiving. And in terms of hours a week, it's 27.3 hours on average, but you're also nearly 1/4 caregivers provide care for 41 or more hours. So this is a full-time job, oftentimes conducted in addition to full-time paid employment. I know that everyone in this room is incredibly busy. For those of you who have not yet been a caregiver in this type of role, I want you to imagine trying to find another 40 hours somehow and what that would mean for your daily life. In terms of what caregivers do, they do absolutely everything. In terms of the IDLs, they're helping patients to get out of bed, to get dressed, to eat. I really want to highlight the fact that 65% of caregivers are assisting with incontinence. You may wonder why I'm highlighting this fact. It's not just that it's 65%. This task that very rarely gets attention. And yet this is a care task that is one of the most physically, emotionally, and existentially challenging tasks for caregivers and for care recipients. This causes incredible distress, and rarely do caregivers get any education or support around this type of work. And very importantly, we know a growing number of caregivers are providing assistance with medical and nursing tasks. I actually was surprised it was only 55% in this report. I thought it would be closer to 80%. And based on my experience within healthcare systems, I dare to say it's probably a bit higher. But we know that the majority of caregivers are asked to perform responsibilities that were once assumed only by trained healthcare professionals such as yourselves, and they're asked to do so without training, education, or support. In terms of working while caregiving, 70% of caregivers are engaging in paid employment, but nonetheless, 18% report high financial strain. So despite the fact that they're working, they still do not have the means necessarily to accommodate all of the responsibilities they have financially as a caregiver. And not surprisingly, when we think about caregivers' own self-reported health, 21% said their health is fair or poor. And what I want to highlight about this 21% is it's the exact same statistic as was found in the 2020 report. There was no change. To me, is very concerning, as when we combine it with the fact that 23% say it's difficult to take care of myself, and 38% report high emotional stress. So these three figures together to me are a red flag. These three say this is a group that is really, really in need of support. Finally, 4% of caregivers report feeling alone. Caregivers historically have been isolated. Certainly the pandemic exacerbated that. For those caregivers who are caring for immunocompromised loved ones, that can become extreme. But I want to also acknowledge something we find even among caregivers who say, I have social support. Even those who say I have social support, when they do not have caregivers in their social support network, they often feel because they feel like no one really gets it. Nobody really understands what it's like. And this is why connecting caregivers with other caregivers can be so very powerful. And finally, because I don't want to just be all negative, 51% of caregivers report that they connect to a sense of meaning or purpose in their role. And this has actually been something I've studied in my research over the past 16 years, and I will turn back to you very briefly at the end. Can anyone guess what the value, the economic value of caregiving in the United States is today? Feel free to shout it out, raise your hand. Guesses. We're going to put a dollar sign on all of the efforts of caregivers. What would it be right now in the United States?
$1 billion.
10 billion. All right, great. That's a great starting point. Anyone else? That was a great starting point. Anyone want to raise it? Lower it? 200 billion. All right. Anyone else? It's good. So I'm going to give you a hint. In 2023, AARP estimated that the value was 600 billion in 2023, but just a month ago, they came out with a new estimate that was much higher. Trillion. Who said that? You're right. I wish I had a prize. I'll think of a prize. $1 trillion. Think of $1 trillion, the economic value of caregiving. That is, if we were to put that dollar sign, and yet we know that 1/4 of caregivers report high financial strain, and nearly a fifth eventually go into poverty as a result of caregiving. So there is a very significant disconnect between the financial value of our efforts as caregivers and the financial toxicity we experience as a result. Great, wonderful. All right. So what does the national landscape of caregivers look like? I want to just, again, take a brief zoom out lens and talk a little bit about what we see across the country. We know that there are a growing number of support programs for caregivers within healthcare systems. I want to be very clear, this list is by no means comprehensive, so I've certainly left programs off the list. These are some that have been in existence for a while, or I'm biased because this has only been in existence for a year and a half, but it's the one that I've created. The VA Caregiver Support Program has been in many ways identified as a gold standard support for caregivers, but of course it's only available to those caregivers whose loved ones are within the VA system. And there are many caregiver-focused national organizations. These are just a few. I want to draw to the National Alliance for Caregiving. This is the organization that conducted that study from which the data I just presented came. They are really the leader in terms of advocacy for family caregivers. And they conduct research and have research partners across the country, including myself and Maya. And one thing about the NAC that they've done recently, they've done state-by-state reports on caregiving. So you all can go to their website and look up Vermont and get data, facts and figures about caregivers within your state. So for anyone who's interested in looking at these data or putting them in a grant application, for example, that's a good place to go. And then I highlight PHI. PHI is the organization that has been the greatest advocate for the direct care workforce. So the paid caregivers, the home health aides, et cetera, who are really working in tandem and complement the efforts of family caregivers. Associations with caregiver interest groups, I highlight AARP, who's really been a leader in this space, and they've recently done the analysis of cost of the caregiving, but they do many, many other projects. And have really been advocates for family caregivers, both for caregivers of older adults, but caregivers more generally. Oops, that should not look like that. Okay, raise your hand if you are familiar with the CARE Act, the Caregiver Advise, Record, Enable Act. I got 3 hands. It's wonderful because I always love to educate. So the CARE Act is currently passed in 45 states and territories. You'll see a state that is left off this list. Which is striking. So the CARE Act has 3 provisions. It says hospitals must document a caregiver's information in the medical record of a patient when a patient's admitted to the hospital. So when my dad was admitted to the hospital, they should document Allison Applebaum and my contact information. The hospital should let the caregiver know when a patient's going to be transferred or discharged. And I think most importantly, a hospital needs to provide caregivers with training and instruction so they know what in the world they need to do when they get home. Now, the reality, even in states where the CARE Act is passed, such as New York State, the CARE Act is not consistently implemented. And this is for many reasons, including understaffing and diffusion of responsibility. And I have argued in other settings that we need to start to identify a caregiver champion, the person on the healthcare team who's going to be the point person for identifying caregivers and providing them with training and instruction. Because if we don't have someone whose responsibility is to do that, it's likely not going to get done. I've also argued in other settings that the CARE Act provides us with an incredible opportunity to take it a few steps further. If we have to identify caregivers and document their data, well, that's a great moment for us to then ask those caregivers how they're doing, and then actually document that data and triage caregivers to support, which is something I'm going to turn back to. In 2022, a national strategy to support caregivers was released from the Raise Act Family Caregiving Advisory Council and the Advisory Council to support grandparents raising grandchildren. This was in collaboration with the Administration for Community Living. And they had five goals. They had five goals, including improved awareness of and outreach to family caregivers, including caregivers in the care team, services and supports for caregivers, financial and employment protections, and data research and best practices. And while I'm not going to get political in this talk today, and there was a dismantling of the ACL, thankfully there's also now a reorganization of the ACL, and these goals remain. What I want to highlight is, regardless of what is happening in government right now, these three goals should be goals that we have in mind, all of us. How can we improve awareness of and outreach to family caregivers of the patients we've seen in our healthcare systems? How can we include caregivers in the healthcare team? How can we develop services and supports for these family caregivers? All right, another national strategy. Who is familiar here with the GUIDE model? Raise your hand. Have you heard of the GUIDE model? I love being able to teach you about all these things. So the GUIDE model, the Guiding and Improved Dementia Experience Model. So this is a voluntary nationwide payment model that is testing out support for patients with Medicare Part B who have dementia and their family caregivers. This began in July of 2024, and it goes for 8 years. And as of now, there are 390 test sites. My institution, Mount Sinai, is a GUIDE model test site. And the GUIDE model sets a standard to care, all billed to the patient with Medicare B. And this includes 24/7 access to a support line, caregiver training, education, and support. And so what it's doing, it's really bundling a lot of caregiver services within a billing and payment model to Medicare under the patient with Medicare's health insurance. Sorry, this is the map of where the test sites exist. And so to keep this in mind, and the way that I think about this right now, we're just in the first 2 years of the GUIDE model. And I think most test sites, including ours, are really still trying to get off the ground. But my hope is that, and forgive this analogy, that this becomes the gateway drug, that we start off with dementia and that we eventually expand to all other illnesses and disabilities, and that caregivers are able to have access to 24/7 support lines and education and instruction, and that we can bill Medicare for these services. So speaking about billing, this is very important for all of you in this room who are able to bill services or will be able to bill for services in the future if you're currently a trainee. We now have what are called Caregiver Training Services Codes, CTS billing codes. So these came out in 2024 from the Centers for Medicare and Medicaid. And these are coding and billing pathways that allow healthcare professionals across a variety of disciplines to provide caregivers with training and education in behavior management, assistance with ADLs and IADLs, and direct care services. And these codes can be used by a variety of healthcare professionals, from physicians and nurse practitioners to PAs, mental health professionals, clinical psychologists, social workers, PT, OT, and speech language therapists. So a variety of healthcare professionals can use these. So these are billing codes, again, under Medicare that basically say, I'm going to take some time to speak to the caregiver about how they're going to care for, it was me, how to care for my dad's catheter at home, or how am I going to navigate that fact. My dad had Lewy body disease and he had a lot of hallucinations. How do I navigate those periods of disorientation? I always advise my mentees never to have a lot of words on slides, so I apologize in advance for the next 2 slides. I just wanted to put the codes, and I can send you'll have access to these slides. These are the literal billing codes that you can all use. I want to highlight the first one, 96202, that allows for behavior management or modification training in a group setting. So hypothetically, you could have a mental health professional lead a group therapy experience where you talk about coping in general, but you infuse in there some training and behavior management. You can use this code. And then again, another slide I apologize for. Just highlighting training and strategies to facilitate the patient's functional performance. And then they updated the codes in 2025. G0541, training and direct care strategies and techniques to support care for patients with an ongoing condition or illness and to reduce complications. These are general, like the descriptions are very general, which I think in part has led to some confusion about how to use them. But from my perspective, really allows flexibility in what we can actually subsume under these codes. They encourage you to think about potentially using these codes moving forward. All right. Back to this image. What about paid family medical leave in this country? We are the only industrial country in the world without a robust national paid family medical leave plan. This means that too many caregivers in this country are forced to make a decision between paid employment and family caregiving. There are only 13 states right now. You'll see Vermont is thankfully one of them, where there is paid family leave. And there is a state-by-state approach being taken, but it's going very, very slowly. And this is really devastating. And this really does translate into extraordinary distress for family caregivers. I really like this statement, which comes from Stacey Lee. She was quoted in the Huffington Post last year. She writes, the United States remains one of the least supportive high-income countries for caregivers. Policies fall short because they were never built to treat caregiving as essential labor. They assume it will happen informally, unpaid, and out of view, usually by women. That's not support, that's systemic erasure. I think one of the most, every word here is important, but I want to highlight essential labor. That is what caregivers are performing, essential labor. And this essential labor translates into very critical outcomes for our patients and for the healthcare system more broadly. And for those of you who work with patients and family members, I know you've seen this firsthand. We know that when caregivers are able to provide labor, it translates into improved patient symptoms and overall health. It translates into improved adherence to treatment. It translates into decreased healthcare utilization and even reduced patient mortality. This is the result of having an available caregiver who's able to provide support. These are really important outcomes. I see people taking pictures. I'll let you take the picture before I move the slide because it's very important. There's a big but. There's a however. All of the outcomes I just mentioned have been linked with various aspects of caregiver psychosocial well-being. So if a caregiver is highly distressed, depressed, traumatized, if they're unable to put food on the table, if they're unable to figure out how to be home because they don't have paid leave, these outcomes are not going to be realized. I want to share one example of this association, a company called Tralta. This is an organization that provides, it's an online platform for New York State caregivers free of charge. It provides education and support. And what they found is they've defined a power user as a caregiver who has spent 10 hours or more on the platform per month, could be watching educational videos, could be receiving one-on-one peer counseling, could be group support. But what they found is those who were power users, 28% are more likely to remain in the caregiving role if they're spending that amount of time getting support, and 32% if they're spending more than 200 minutes, so just a few hours on the platform. And I think what's so striking is power users, the utilization rate is significantly lower for power users, meaning those caregivers who are getting support, who are getting their information needs met, who are feeling more prepared, are less likely to call an ambulance, are less likely to take their care partners to the hospital, are more likely to be able to problem solve at home, and likely be preventing that hospitalization in the first place. So this is why I think of the work that I've been doing, not only as preventative medicine, but for patients and the healthcare system as well. Oh, Okay. So I want to turn now to distress and caregiver burden. Caregiver burden is a catch-all phrase that refers to all the negative ways in which the caregiving role can potentially negatively impact the caregiver. And it has many components, the first of which is psychological. So we know, this might be one of the most important statements I say today, we know that diagnostic rates of anxiety, depression, and even post-traumatic stress disorder are higher in caregivers than the patients for whom they provide care. Right? This is why I do the work I do as a clinical psychologist. We know that caregivers are also at risk for their own physical and medical problems, including cardiovascular disease, poor immune functioning, fatigue and sleep difficulties, and even higher rates of mortality. I often open my grants by saying, without support, caregivers represent the next generation of patients living with chronic and life-limiting illnesses. Talk about the financial component, the social component being the isolation, which I've already referenced, as well as there's a spiritual and an existential component to burden. The spiritual being many caregivers have a crisis in faith, right? Why me? Why him? Why us? He was so healthy. He exercised every day of his life, never drank alcohol, and now he has this advanced cancer diagnosis. There must be no God. There's no rhyme or reason to life. Ooh. Hello. And then the existential being the distress that we all experience when we realize that we are human. If anyone disagrees in this room, let me know. That we are mortal, and that we and everyone who we love will all eventually die, right? Every one of us experiences this in really multiple times across our life. For caregivers, this comes up in a particularly powerful way. My colleague Nick Odom highlighted in this article drivers of increased and continued stress, specifically in the setting of cancer caregiving, but I'm highlighting these because I think these points apply to all caregivers. And the first are an increasing number of patients living with advanced disease. And the reality, which is a beautiful thing, is our therapeutic technologies are improving, right? Patients are living longer. In the setting of cancer care, cancer is no longer necessarily a death sentence, but as patients live longer, that means caregivers are in the role for much longer periods of time and have extended responsibility. Number two, there are an increasing number of patients with significant comorbidities. It is very rare to meet a patient who just carries a diagnosis of dementia, for example, right? It's often dementia and diabetes or dementia and cardiovascular disease. And with each additional comorbidity, that means additional responsibilities for caregivers. Number three, there is a significant push to outpatient and homebound care. This was long before the pandemic on caregivers. And I want to give you one example that really propelled me in this work early on. Talking about in a moment my experience at Sloan Kettering during my postdoctoral fellowship. This was 2010. As fellows, we were required to review protocols for the IRB. And I had been assigned a protocol from the bone marrow transplant service. And they were piloting, at the time, their very novel outpatient and homebound transplant protocol, where a patient would get a stem cell transplantation in the hospital, and then they would be discharged to home, which was great for patients, right? We don't have to stay in the hospital. What was so striking to me as I read through the protocol was the consent form. Because the consent form said, in order for a patient to qualify for that transplant, they needed to have a caregiver available 24/7 for at least 1 month. And it said ideally up to 100 days post-transplant. Think about that. So I thought to myself, wow, what an incredible ask, right? And if we were asking caregivers to be available in this way, then we better as an institution and as a field do something to support caregivers, which I'll turn back to. That's one example. There are many, many, many examples of this now. And it is often just assumed when patients are discharged from the hospital that a caregiver will be available. It's just assumed that they'll be available at all times, day and night, to manage responsibilities. And what we were asking caregivers to do at home is very complex. It's not just potentially taking a vital sign, it's navigating catheters and wound care and PICC lines. Again, tasks that were really assumed by trained healthcare professionals and are really putting caregivers in the nursing and physician role at home. I also want to acknowledge another driver of distress, which is an increased period of incapacity pre-death. Now, many patients choose to die at home who have the ability to make that choice to say, I want to go into home hospice. And I want to be very clear, there's no right decision here. For many patients, that's the right decision. For many patients is I want to die in the hospital. But I do want to acknowledge that when this is the decision, this often leads to a very complex emotional situation for caregivers. Because at the same time that they are deeply engaged in anticipatory grief, they're also tasked with providing intense levels of physical medical care. So this is a very, very difficult period and a driver of distress. The cost of medical care is significant. I've already sort of driven that home. And many caregivers are providing care from a distance, which adds complexity. So these are all drivers of distress. We know when it's left untreated, this is a cancer caregiving trajectory, but we can extrapolate to any other illness. When left unaddressed, this distress is going to increase exponentially. So if a caregiver is distressed at the time of their loved one's diagnosis and we don't do anything, it's only going to get worse. This is why early intervention right over here in this period is so important. I'm going to be talking about that in a few minutes. I also want to highlight that there are particular points along this continuum in which caregivers are at unique risk for distress. And I know that these two categories are of no surprise to anyone, right? A patient transitions to hospice care, a caregiver into bereavement. Obviously, this is a devastating period. But I've highlighted survivorship, and I'm going to ask the audience again, do you have any guesses as to why I've highlighted survivorship as a period when there's high distress in caregivers? In the setting of cancer, this is a period when a patient's told, you've no evidence of disease, the cancer's gone, we're going to stop your treatment, come back maybe in 6 months for a scan. With my dad who had Lewy body disease, it was a period when his symptoms were controlled and he wasn't hallucinating regularly. Why might this then be a difficult period for caregivers? Does anyone have a guess? Yeah, in the back. Fear of recurrence. Big. Yeah, that's right. What else?
Not how long it'll last.
Yeah.
And then how much can I step out of it?
Totally. Uncertainty. Yeah. Can I really relax? Yeah. Is there anything else? These are both right. I'm going to add to those the fact that oftentimes what we see, so for patients, survivorship is a period of increased well-being, right? They'll say, for many, there's a new lease on life. Many are eager to get back to their new normal. We often see in caregivers, paradoxically, when they take an exhale in survivorship that they weren't able to take before, because before they were in fight or flight mode, right? Going for that first and second and fifth opinion, putting all into the care of their loved ones, not necessarily allowing themselves to come into full contact with the negative emotions they inevitably were experiencing. And once their loved one is okay, safe, they take an exhale, and with that exhale comes a rushing in of all those negative emotions. So there's avoidance that happens inevitably for caregivers. And so we actually see a very significant spike in distress in caregivers and survivorship. And very importantly, from a health systems perspective, I want you to keep this on your radars. From a health systems perspective, what's happening in survivorship? Families are not coming back as frequently, right? We are discharging patients. We are saying, come back in 6 months or a year. So this is actually a really important moment when anyone in this room, you're discharging a patient, they're not going to come back for a while, and the caregiver's in the room. This is a great moment to check in with the caregiver. How are you doing? How can we provide support to you? What are your needs? Please keep that on your radar. So I mentioned my fellowship at Sloan Kettering. I came to this work through that fellowship. And in my first year, I was working primarily with patients at end of life. I'm a clinical psychologist by training, so I was providing psychotherapy. And what was so striking to me as I sat with patient after patient after patient was, as opposed to their focusing on their own, which I would anticipate would be their greatest concern, they were focused on their parents and partners and children and siblings and friends. They were focused on the individuals left in the waiting rooms and left at home, the individuals who they identified as the linchpin of their care and who would be most deeply impacted by their eventual deaths. And I realized back then, this is 2010, long before the pandemic, that cancer care specifically, but healthcare more broadly, was really relying on caregivers. And I had that experience with that bone marrow transplant protocol that really drove it home for me. And I also realized that the scientific literature had already very well documented caregiver burden and distress, but there were no targeted support services for caregivers in any cancer center in the country. And so a year later in 2011, I founded the Caregivers Clinic at Sloan Kettering, whose mission is to assure that no caregiver experiencing significant distress as a result of their critical role goes unidentified and deprived of necessary psychosocial services. The clinic provides care to caregivers of patients with all sites and stages of cancer, from diagnosis through bereavement. One of the foundational steps that I took when I established the clinic is I advocated that caregivers would become patients' healthcare system themselves, with their own medical record and their own medical record number. I had learned that on occasion, caregivers had been seen by my psychiatry colleagues, but their data had been documented in the record of the patient with cancer, which of course leads to questions about confidentiality and privacy, and also who's the patient, right? If my data, Allison Applebaum's data, were documented in my dad, Stan Applebaum's record, is the patient Stan Applebaum or is it Allison Applebaum, right? And then the question is, well, whose insurance should get billed, right? Having a medical record in place, of course, allows us to navigate privacy and confidentiality, preserve them. It allows for us to preserve continuity of care into bereavement. And very importantly, from the administrator's perspectives and mine, having the record in place allows us to have an ethical mechanism to bill for services. And so this is something that I've been advocating for, that we should be having medical records in place for caregivers. There's many reasons why caregivers have come to the Sloan Kettering Caregivers Clinic. These are the 4 most common categories of referral, though this is not a comprehensive list of every reason folks come in. Navigating anxiety, how do we balance caregiving with other responsibilities? Caregiving rarely happens in a vacuum, right? It's often superimposed upon other life stressors like job loss or divorce or another death in the family. Communication skills is a really striking. So within the first few months opening, it was so striking as how many caregivers came in and said, Dr. Applebaum, I have no idea how to speak to my husband about his illness. Or am I even allowed to speak up in the visit with the oncologist? As the caregiver, as a family member, am I even allowed to speak in these visits? Like, what's my role? And it became very clear to me that caregivers really needed assistance with communications, the big ones, big drivers of distress. And then finally, that existential distress. Caregivers struggling to balance the question of how do I live as fully as possible in the present moment with my husband while knowing that he's going to die, I want to remarry in the future. Or how do I envision my life in the future when I've actually I put work aside. I don't even know who I am as a person anymore because caregiving's taken away my sense of identity. These sorts of existential questions that come up. During the pandemic, which was generally not a great time to do research, Dr. Odom and I and others, I don't know if we're on this study, conducted a study where we evaluated the availability of caregiver support programs in cancer centers across the US. And we defined a caregiver support program as anything from the Caregivers Clinic at Sloan Kettering, so this comprehensive psychosocial care program, to simply giving a pamphlet of information to a caregiver or saying, I have a referral for you in the community. So a wide range of support, right? We had 238 cancer centers respond to our questionnaire. We had sent out over 900, but this during the pandemic. What's striking is 75% of the cancer centers said, yes, we have a program, the top bar. But I wonder if you can guess what was the most common type of program that they had. It was referral to the community or a pamphlet of information. I don't want to be totally negative, but I want to turn that upside down. That means 20% of cancer centers didn't have anything. We're not even providing information. We're not even providing referral to the community. And that to me is something that needs to be changed immediately. We asked about barriers to developing caregiver support programs, and the number one barrier cited was concerns about the financial viability of caregiver support. How in the world will we support such a program? The answer that we have in the back of our minds is, well, if you have medical records in place for caregivers, well, you have a mechanism then to bill for services and generate revenue. So that problem actually can be solved. As of last year, there have been 1,000 randomized controlled trials conducted to evaluate the benefits of psychosocial interventions for caregivers. So the science of caregiving intervention work has moved quickly and powerfully, and yet without infrastructure on the ground, without staffing on the ground within healthcare systems to deliver these interventions are just going to sit on a shelf and caregivers are going to remain unsupported. So I want to talk very briefly about some steps that I and my colleagues have taken to begin to address this concern. We began by publishing this toolkit with the American Cancer Society. It's available free of charge to everyone on the ACS website. This is the Cliff Notes version of all the steps that I took to establish the Caregivers Clinic at Sloan Kettering, making it really clear for anyone who wants to establish a program, the steps that you would need to take, everything from demonstrating the demand to convincing your administrators and leadership to staffing models. And to take it a step further, Dr. Odom and I were very pleased that the NCI funded an R25 training program called our Insight, Increasing Caregiver Support Implementation through Training and Education training program that is allowing us to train up to 200 counselors for the next 5 years to develop caregiver support programs. Certainly, we would welcome folks from this institution to come join us for one of our trainings. So I spent 15 years at Sloan Kettering. I transitioned to the Icahn School of Medicine at Mount Sinai in September of 2024 to lead the newly established Stephen S. Allbaum Family Center for Caregiving. Just very briefly, the Center for Caregiving has 4 components to it, including a caregiver support program, which is the Sinai version of the Caregivers Clinic, which serves caregivers of patients across the Mount Sinai Health System, not just those with cancer. We have a research program really focused on testing interventions and figuring out how we can best serve caregivers, patients, and the healthcare system. Very excitingly to me, we have a dissemination and advocacy arm, and this is in collaboration with the Center to Advance Palliative Care, or CAPC. You may have heard of CAPC, where we are synthesizing the best practices in caregiver support. We have now written up the case for caregiver support, which we are now currently disseminating to healthcare systems across the country. And we're developing tools, training, and technical assistance. So no one needs to do what I did. No one needs to be an N of 1 caregivers clinic. That's how it began, but can actually start with all the tools you need, not from scratch, to develop a program. And finally, we were just sort of sharing earlier how there's not that many of us in academic medicine focused on studying caregivers. And so it's really important that we train the next generation of caregiving scientists. So we are training pre- and postdoctoral fellows, so we can create that new pipeline of investigators. I'm looking at time. I'm going to go quickly. So this was a snapshot of my program of research at the time that I left Sloan Kettering. What I highlight about my research and the work that I've done over the years, number one, is that there's no one-size-fits-all approach to supporting caregivers. What caregivers need early on at a point of patient's diagnosis is very different from what they need at a point when their loved one may have a cancer recurrence or a disease progression, which is different from what they would need when they're transitioning into bereavement, right? Number two, we don't need to reinvent the wheel. We do not need another cognitive behavioral therapy intervention for caregivers. We know CBT works, right? We don't need to prove that again. What we do need to figure out is how we can deliver our empirically supported approaches in manners that are feasible and acceptable to caregivers at vulnerable moments. So, for example, my postdoc, Dr. Leah Walsh, is studying the transition period from hospital to home, which is a very stressful time for a caregiver. And we're figuring out how can we best deliver a CBT protocol during this vulnerable time to maximize benefit. And then number three, I just want to say all of the research I've conducted, all of the questions I asked were born out of my clinical experience, like the communication skills training program I've developed for caregivers was a result of the fact that every caregiver came in and said, I don't know what to say. So we've developed a training program to help them communicate with their loved ones. Before time runs out, I just want to speak briefly. I'm going to rush through these slides. I'm noticing the time. I want to talk about a trial I conducted on distress screening in caregivers. I'm going to start with a punchline, which is that distress screening is a powerful intervention. This study was published in Psycho-Oncology, and I'm happy to send the full text if you don't have access. You may be familiar with the distress thermometer. This is a visual analog scale that's really widely used in cancer care. It was developed by my colleagues, Dr. Andy Roth and Jimmy Holland. And I don't love the distress thermometer. Say, how distressed are you from 0 to 10, right? And then you check off drivers of your distress. If you asked me to take the distress thermometer a half an hour ago, and then to take it now, and then to take it in an hour from now, I'm probably going to give 3 different ratings of distress. So the meaningfulness of this distress rating to me is not incredibly clear. And so in thinking about if I were to screen caregivers for distress, I decided to partner with the Cancer Support Community, which is a community-based organization that developed this comprehensive tool called the Cancer Support Source Caregiver that attends to every element of burden. I'm not going to read them out. But what I love most about this tool, for anyone who might want to use it, is that it allows you to build into the back end information specific to UVM. So for example, when we did this at Sloan Kettering, caregivers did a 33-item web-based tool. They hit submit. Let's pretend the caregiver said, I am concerned about finances, or I'm concerned about putting food on the table. They would immediately be emailed information about Sloan Kettering patient financial services. So not only screen for distress and burden, but it actually allows for triage immediately and referral to necessary services. And so I wanted to explore whether or not simply giving this screening tool and doing a consultation, which was a less than 5-minute phone call between 3 and 6 days later, would have any impact on emotional well-being. No other intervention. We randomized 75 caregivers to get the screening and consultation. 75 got what's called Enhanced Usual Care, EUC, which was here's a pamphlet of information about all the services Sloan Kettering for caregivers. Our caregivers were predominantly female, white, non-Hispanic, high SES, high employment. This is a typical Sloan Kettering caregiver. Our caregivers were predominantly the spouse or partner of the patient, and the majority were recruited from the Josie Robertson Surgical Center, JRSC. This is an outpatient surgical center where patients come for the diagnostic procedures, the prostatectomies, the lumpectomies, that sort of thing. So these are mostly patients newly in role. However, like the other things I presented, this was conducted during the pandemic. And halfway through recruitment, Josie Robertson became a COVID hospital. And so we then transitioned recruitment to the main hospital of Sloan Kettering and the bone marrow transplant service. And so when we look at the months spent caregiving, the majority had been in the role for less than 4 months, most likely recruited from Josie Robertson, but we see 9% had been in the role for over 2 years. Similarly, 57% provided care for less than 4 hours a day, but you see 12% were 24-hour caregiving. And the majority provided care from the point of diagnosis and cohabitated with patients. In terms of baseline problems reported, none of these were surprising. Caregivers said the most common physical problem I have is feeling too tired to do the things I want to do. The most common logistic problem is how do I balance caregiving with everything else on my plate? The most common emotional problem is worrying about the future and what lies ahead. And the most common patient-specific problem is concern about the patient's cancer progressing. What was so striking is at 6 months, those caregivers who got the screening and consultation reported significant improvements in emotional well-being. There was no significant difference in psychosocial service use. So it's not that every caregiver who got the screening came to the caregivers clinic. In fact, only 3 came. I don't know what that says about our PR, but only 3 came. So I was wondering what's driving this? What's driving this? So we collected qualitative data. I think it really tells a story. One caregiver said the notion that somebody cares, even if it's the hospital, about how you're doing is really powerful. And that's probably what I took away from this the most. Another caregiver, I don't think I know it right now, but it's really good to know it's here in case I do in the future if things get worse. Across interviews, caregivers said that the screening protocol helped them to feel seen and validated and valued and cared about. A few caregivers said this was the first time anyone had asked them how they were doing. A few said it's really nice to know Sloan Kettering cares. That is a powerful message. This quote comes from a participant from the NASM workshop in 2025. A caregiver said the biggest barrier has been feeling unseen and not believed as the family caregiver. This is what each of you in this room can very easily address with 3 simple words. How are you? I encourage each of you, each time you come into contact with caregivers, to ask this question and to follow up with, and how can I or my team help to get you this need? Which also means they figure out who you need to talk to get that support. I am not being dramatic when I say that I strongly believe that asking this question for every caregiver has the potential to mean the difference between life and quality of life. And for a small but very critical subset of caregivers, this question will mean the difference between life and death. Some of my goals for the future: I can retire when, distress screening, psychosocial care programs, and the documentation of caregivers all become standards of care, which means I may never retire. We'll see. But these are really important, and these are actually steps that every institution can be taking, and they don't cost anything to do. So steps that you all can take, your first steps I hope you all will think about taking in the near future. Identify caregivers. Identifying caregivers is an intervention, shining a spotlight on who they are. Not every caregiver automatically identifies as a caregiver. Let's say, I'm the daughter. I mean, that's how I felt, right? I was doing everything for my dad. I adored my father. I miss him desperately, but I was his caregiver. People will say, well, I'm the husband. I'm doing what I would do when I married her. But identify caregivers. That is an intervention. And then screen them for distress. Now, whether you use a distress thermometer, the cancer support source caregiver, the Xeric burden inventory, or the 3-word question, anything else, these are all powerful interventions. And then really consider documenting caregiver data in separate medical records. I was often, when I started this practice at Sloan Kettering, and I would speak like I am today about this practice, folks would say, well, you can only do that at Sloan Kettering because that's a special institution, Sloan Kettering. I'm like, well, I don't think it's a special institution. And also, it literally takes a few identifiers and a few minutes of time. It's not a huge lift to create a medical record. It's only going to get easier with AI. And then I think it's very important that every institution creates a comprehensive list of community referrals. Because even when, I'm not saying if, even when you all develop your robust caregiver support program here, you still are not going to be able to meet the needs of all the caregivers of this institution. And it's going to be very important that you have a list of folks in the community to whom you can refer. And I say warm handoff because I cannot tell you how overwhelming it is for a caregiver to get a list of referrals when they're distressed. Here's 20 providers, you figure it out. That's really distressing. What I encourage you to do is actually facilitate the referral. Speak to the person in the community. Ask, do you have room for this caregiver in your practice? And then give the caregiver the phone number. If you want to take it a step further to go beyond the basics, of course, advocate for staffing positions for mental health professionals to support caregivers. And that may mean thinking about folks already hired with the institution who may be able to begin to devote some of their time and effort to caregiver support. Caregiver Advisory Board. It is so important that the voices of caregivers make it into the programs you're developing, the research you're conducting. Have the caregivers here tell you what they need. Have them tell you what it's like to be a caregiver in this institution. It is likely different to be a caregiver here than it is at Mount Sinai, than it is at Sloan Kettering, than it is at the University of Alabama. Find out what those differences are. I encourage you to track caregiver outcomes. How are they doing? Anxiety, depression, trauma, preparedness, burden, but also patient and health systems outcomes. Why? Because that's what we want. Those are the data we need to convince our administrators. These are the data we need to show our government why this is so important. If we support caregivers, we're going to have better outcomes for patients and our healthcare system more broadly. And finally, I really encourage you to all of you right now, because I think many of you in this room are probably in the position to do so, just start using those CTS codes, the Caregiver Training Services codes. Take some time to train a caregiver, educate them, and remember that you can actually bill for that. And I think that will incentivize increasingly using the codes and spending more time with caregivers. I want to end by going back to the statistic that 56% of caregivers in the United States today say the role brings them a sense of meaning and purpose. Taking care of my dad for nearly a decade was one of the most challenging experiences of my life, but it was, to date, the most meaningful. I would have been unable to connect to meaning or purpose had my basic needs not been met. Had I not been able to secure Medicaid for my father and eventually have a team of home health aides help to take care of. Had I not been able to continue to work, had I not been able to have my own psychotherapy, my own mental health care. And I say that because if everyone in this room is going to be a caregiver at some point, well, I hope that everyone gets to experience meaning and purpose. But if our basic needs aren't met, if we don't have basic support, that's not going to happen. And this is really why all of us should think very hard about how we can take steps right now to improve support for family caregivers. Thank you so much. We have a whopping 4 minutes for questions. Yeah.
Let's comment on the state of respite care for caregivers in this country.
It's pretty poor. The state of respite care is very, very poor. And I think this is something that needs to be addressed. I will say respite care is part of the guide model, that guiding and experience, the dementia model. But the respite care services are few and far between and so desperately needed. Yeah.
Well, we continue to advocate for that as well.
Absolutely. Yeah.
I was wondering if you could comment on the, that's what.
Yeah.
If you could comment on the differences in caregiver distress between caregivers in urban areas versus rural areas. I would imagine that issues such as isolation, financial distress, and food insecurity may be quite
much
different.
higher, right? So absolutely, the distress is disproportionately higher for folks who are isolated in rural communities, who are not connected to large institutions, to the major cancer centers, the major hospitals, and are less likely to have access to services. And so this is actually a group who's really a focus of a lot of the research that's happening now in terms of how to improve access. A lot of via telehealth, a lot of it through digital, which are being developed. But rural caregivers are really in high need of support. Yeah.
I wonder if you have any training for the family members of the caregiver, because I think so much of the burden lands on one person usually, and then there's all these other family members that might be telling that person what to do and etc.
Yeah, so there's a net, right. So rarely is there just one person involved. Well, let me start by saying there's another elephant in the room, which is in that not every patient has a caregiver, right? And this is something that we as a healthcare system need to be addressing, that more and more patients are going to be coming in and saying, I don't have any family. I don't have a husband or partner. I don't have children. I don't have close friends. Who's going to help, right? I just want to acknowledge that's something that we think very creatively and flexibly about, because I think it's only going to increase. But then the other side of it is that in many circumstances, there's a network of care where there's one person who's primarily involved, was me, and then there's other potentially available people who have lots of opinions. This is where having even 1 or 2 sessions with a social worker or mental health professional can be very powerful to help to navigate how to delegate responsibilities and division of responsibilities. We often encourage caregivers who are the identified primary, create a list of everything you need to do, from big to small, right? Anything that's caregiving related, particularly to doing the grocery shopping or cleaning the home, and then figure out to whom these can be delegated. The other area where this becomes increasingly complicated, though, is around advanced care planning, right? If there's one caregiver who's identified as the healthcare proxy, the surrogate decision maker, but we have the siblings who are all weighing in about what mom or dad might want, that too gets very complicated. That's another reason why a session in your to be developed, hopefully, caregiver support program could help to flesh that out, because that can get very, very complicated. Yeah. Yeah.
Is there data?
I can hear you. Oh, they went out. Sorry.
Is there data as regards the patient outliving, surviving the caregiver?
Yeah, I love this. Thank you so much. So we are starting to see, and unfortunately we've seen in our own clinical practice, that oftentimes in the context of caregiving, caregivers become the patients themselves. And that oftentimes, I hate to say, caregivers will die before the patient. I have not seen any sort of large controlled trial evaluate these out. I can say anecdotally from our experience at Sloan Kettering, 10 caregivers who eventually either went on to provide care because of their own illness or eventually died. We had a handful of sudden cardiac deaths. Yeah, and so I'm very, when I say the life and death piece, it's for many reasons. One of which is that, and I didn't say this specifically, but suicidality, rates of suicide, very higher in caregivers than the general population. So that's just to keep on the radar. But then what you brought up, thankfully, is the fact that many caregivers eventually get diagnosed with their own major medical illnesses or have a sudden event because they haven't.
Exacerbated by stress.
100%.
Or they start out with their own.
They start with their own that gets exacerbated because they haven't had time. They're not prioritizing. They can't get to the doctor's appointment. I'm guilty as charged. I delayed a mammogram multiple times because it meant that I'd have to take time away from my dad. And it was only after he died that I eventually went. And, you know, I did put myself at risk. Right.
I think we're at time. So thank you so much. This is wonderful. And thanks everybody for being.
We'll post it on the Osher Center website.